Today I'll take several minutes to give an example of how to use repeated movement testing with a patient complaint of central, mid to lower neck pain. So there's three parts of my orthopedic evaluation. I'm going to gloss over the first part, the specific verbal history, and we can just say that either nothing jumped out at us or nothing was giving us the idea that there was a red flag that would be against us using repeated movements or other movements with the patient. And let's go to the baselines. So the pain is, let's say it's not even there when the patient presents to the office, but when it is there, again, central, lower to mid cervical spine. Now, there are 8 motions of the neck. So I'm gonna run through a hypothetical case of those 8 motions. So we can look at protrusion and say the patient says there's no pain and it looks like full range of motion. Flexion, I'll write down that there's full range of motion and the patient says there's some pain when they get to the end range. Retraction, let's say it's full range of motion, but there's some pain during the motion. Extension, I'll put for this patient that is limited, minimal loss with some pain at end range. Right rotation, full and pain-free. Left rotation, we'll say minimal loss with pain at end range. Side bending, full and pain-free. Side bending, full but some pain at end range. So those are our mechanical baselines. I will not do nerve tension for a patient with central spine pain. And I probably wouldn't even take the time to do any myotome testing for this type of clinical presentation. So therefore, I might look at postural adjustments in the clinic, but often if the patient's presenting asymptomatically, I will not broach the subject of posture quite yet. So let's go to part 3, repeated movement testing. And again, if other clinicians are using different tests, they can use them at this juncture as well. But the main testing I use with patients is repeated movement testing. And in rare cases, I will use a clinical orthopedic special test or advise the patient to get an X-ray or MRI. So repeated movement testing, my inclination for this patient, considering that the symptoms are in the lower and mid cervical spine, is to start with retraction extension. And for neck patients, if the person doesn't seem highly irritable, I might do 10 repetitions or 6 repetitions. There's lots of different data points. Let's just say we do 6. And so I have the patient do retraction, extension, and the person says, yes, it's pretty symptomatic. It creates their specific pain when they go from retraction extension during the range of motion. So in my evaluation assessment form, I write down what happens during the motion. So for this patient, it would be seated retraction extension produces central neck pain during, and when the patient comes back to seated afterwards, they return to their asymptomatic state. So the pain was brief during the motion and it goes away. So let's say I have the person do 5 or 6 and each time it's retract, extend, and let's say by number 6, I ask the patient what's going on the more you do, and they say it's a little bit less painful and I feel a little bit looser. So then after that set, I'll probably recheck the baseline. So if I have time, I can do all of them that were problematic to begin with. Protrusion, for example, wasn't problematic, but flexion was. So I can say, all right, flex again and tell me, is it worse, better, about the same? And I try not to ask leading questions because I really want to be a cause and effect clinician and not be dogmatic about any of these things or try to make the patient want to give me the answer they think I want. So let's say the patient says, it's still there, it's about the same. Okay, well then I'll look at retraction. Is the pain still at end range? Oh, it's a little bit better. Okay. I might not look at the right rotation and the right side bend because they were full and pain-free, but I will at some point because, again, taking a snapshot of range of motion just one time doesn't tell me if that's truly the patient's full range of motion. The right rotation may have looked great according to norms for that person's age, but that person might have more, and we might get more just by some simple repeated movements. But I definitely want to look at the left compartment because it was limited and painful before. So I'll have the patient left rotate. I'll ask the patient, is that worse, better, about the same? And while I'm asking those questions, which give me the subjective report, I'm also looking, of course, to see, do I think the range of motion has become more limited, has become increased, or is about the same? So we'll say that person says, it's about the same. And then side bend, the person will say it's a little bit looser, a little bit less painful. And then extension, pure extension, I will look to see, possibly getting up next to the patient on the side, if I feel like we've gotten some range of motion. And the patient, let's say, says it feels about the same, but what I observe is that there's more range of motion into extension. So I'll do another set of retraction extension because there were some things that stayed the same and some things that were a little bit better. So there's no red light or worsening of mechanics, and there's no worsening of symptoms, meaning the person who comes in without symptoms, now we've made them hurt. So because there's no red light, I need to do more. Repeated movement testing is called repeated for a reason. It's not just 1, 2, 5, or 10. It's more to get answers in a safe and appropriate way. So we'll do another set, retraction, extension. Every time I'm asking the patient what's happening during. Is it getting looser? Is it getting tighter? Is the pain that you feel when you get to that end range each time getting worse, getting better, changing, spreading to the scapula, spreading to the shoulder, giving you a headache? All these kinds of questions. I'm trying to get those answers as we do just 5 or 6 over the course of 30 seconds or so. So let's say the patient says, oh yeah, now it feels better and I feel like I'm getting looser. It's not that painful during that motion. So we'll do 6. I've got the answer that it's feeling a little bit looser and less painful, and I'll retest those baselines. Let's say this time flexion it's a tiny bit better, but it's still provocative. And let's say extension is, the person's like, oh yeah, that's definitely better than before we started. And then left rotation, it's a little bit better. And then left side bend, I'll note that range of motion is better, and the patient says the pain is still there, but it's less. So in this scenario, I'll probably do a 3rd and a 4th set. And for the intent of this, the purposes of this video, let's just say that we do 2 more sets of 6 or so, and things get a little bit better, but nothing is completely abolished. It still produces some pain during the motion, but it's less than when we started, but it's bearable. We don't have to use training wheels, as I call it, to support the head. The patient can do it, go into that pain, and come out of it and be asymptomatic. So I've noted in my paperwork that it's producing the familiar pain during, but it's not staying painful after. So in my nomenclature, using MDT, that would be produce, not worse. So we produce the pain, it's not worse after. In contrast, sometimes it's produce the pain worse. So you've produced the pain, and now the person after the set of repeated movements is worse. And that would be an indication that you're probably going in the wrong direction, but it depends. You have to take all the data into the algorithm and see what it spits out. But in my notes, I'll write, increase left rotation, increase left side bend with decreased pain, decrease pain with full flexion, decrease pain, increase range of motion with extension. So this is a very simple case, but it's something that I see very commonly. Even if it's not central neck pain, it might be central right, or just right scap, or just left shoulder, or just left elbow. So central neck pain is almost always going to respond to a sagittal repeated movement. So retraction or extension, retraction, extension, protrusion or flexion, or some combination of those sagittal motions versus a movement to the side, like a side bend or rotation. It's the same with the lumbar spine and the thoracic spine. If the if the pain is central, typically responds to a movement in the sagittal plane. Not always. And when we're talking about asymmetrical symptoms, so maybe center and right scapula or just right scapula, then the incidence of having to do a lateral motion like a side bend or a rotation increases. although it's not more than half. I would say in the neck, I think colleagues of mine have amalgamated some data and found that it's only about 25% of the time that we have to go out of the sagittal plane when it comes to treating problems that are coming from the cervical spine. So we can fast forward a little bit. I would likely talk about posture if I think that going into retraction extension is going to be the fruitful therapeutic exercise for this patient. Then it would behoove us to talk about, is your posture in a lot of flexion or in a lot of protrusion in the car, at home, in the office? Because if it is, then it can kind of prevent us from getting all we need from this exercise as therapy, because it's countering what we're doing. If we're moving into retraction extension every 2 hours for a set of 6 to 10, but those other, hour and 59 minutes are in protrusion or flexion, we're not going to really get very far with our therapeutic approaches. I sometimes use the analogy with patients about pushing a boulder up a hill. And I don't know if that really resonates with people. I'm always trying to find ways of explaining things, but the dosage for repeated movements, if I'm investigating or if I'm treating, and that line is often blurry, but the dosage is the key. It's every few hours as a frequency. Again, how many you do in that set might be a little bit different, but it tends to be around 10 repetitions. But you cannot do 100 in the morning and call it a day. It's not strengthening a muscle. It's not stretching a muscle. It's not, doing any number of things that would require a different frequency. This frequency is like pushing a boulder up a hill. You move that joint, and the next 2 hours or so, it's going to move back down. You got to move it back up again, and it's going to move back down a little bit. And once you achieve enough repetitions, it will stay good, and then you'll have a prevention and maintenance program. But it's not like strengthening a muscle that you can do once a day or 3 times or 4 times a week. It needs that stimulus every few hours for a few days to weeks, especially if in those intervening few hours you're doing things that you cannot avoid that would be antithetical to that movement. So if we fast forward and say that this person comes back on visit 2 and notices frequency of pain throughout the day is down 50%, we're on the right track. And at visit 2, my job is to go through repeated movement testing with the same movement again, seated retraction extension, and assess if there's still going to be continued benefit. So I'm kind of choosing between, do I need just more reps of the exact same thing? We're doing well, and if we do 30 or 40 in the office, I can still see a cause and effect relationship that benefits the patient's mechanics. Or do I need more force? Have we plateaued with this amount of force and we need more force, perhaps doing some rotation at the end range, or pushing over a chair, or pushing the chin back with the fingers? Or would we need a different loading strategy? Maybe retraction extension in supine, off the table, or maybe in prone. Those are probably the different thought processes that would go through my mind if someone's coming back 50% better, having done the prescription as prescribed. And if really distant thought would be going out of the sagittal plane or into a forward motion of the sagittal plane, because 50% reduction of symptoms is usually quite good for a few days. And I'm typically happy on the whole with like a 30% change in presentation, but it does vary based on the severity of the disorder, the chronicity, other health factors, how much you were able to minimize protrusion and flexion, etc. So clinical care is based on a lot of different factors, and simple problems can be, fixed with definitely listening to YouTube videos and videos online and reading books. But expert care should really be able to take into account all these different points about that individual patient. So let's say the person, I keep it the same, they come back on visit 3, 90% better, maybe a week later, I'll probably flex that neck to make sure that it's not vulnerable to a kind of acute re-injury, and send that person home with a flexion plus retraction extension program, and that's kind of just the return to function, making sure the patient's not afraid of flexing, making sure that the tissues haven't gotten tight by avoiding flexion for a week and a half or so. But in this case, the repeated movement testing would bear out because we were able to restore normal mechanics, which I'm mentioning now. Let's say everything is full and pain-free. Restoring mechanics, eliminating symptoms. We can call this a joint derangement. It is an orthopedic disorder where moving into a specific direction repeatedly restores that joint to normal, which is in contrast to, arthritis or instability or weakness or myofascial pain syndrome. So it's a distinct diagnosis put forth by Robin McKenzie. It's what I find in 70 to 80% of patients, higher in the spine than the extremities in terms of percentage. But it's what I see all the time. So this person has a joint derangement in the cervical spine. I don't have to be precise about the location because we're moving the entire cervical spine, upper, mid, and lower. But based on the pain location, we know it's likely one of the joints in the mid to lower cervical spine. Joint derangement diagnosis solved with a directional preference of repeated retraction extension in sitting, which is different than lying in prone or supine. And my job is to make the patient aware of how these things are common. An imbalance in the joints position over time is hypothesized to be the cause of most of these. But of course, one night of sleeping in a wrong position or wacky position or a fall or any kind of, acute disruption to a joint can cause a joint derangement. But for most people, we can kind of hypothesize that some of their sitting posture plays a role, go over some prevention and maintenance strategies for this patient, and make them empowered. Since I haven't used my hands for treatment, make that person empowered not only to understand how to keep joints healthy and prevent or minimize recurrence, but they have the tools of how to treat it prophylactically or prevent it, and then how to treat it when symptoms inevitably arise at some point down the road, but hopefully minimally, and the person has that power to treat him or herself without having to go back into the medical care system.